Hey y'all, this is Sarah Mel. Thanks for tuning in to Phases of the Womb podcast. All right, y'all. So today we are talking to my wonderful friend and colleague, Abeth. We previously worked together on 2 assignments, one in Berkeley, California, and one in Bellevue, Washington. She has a unique experience as a mom of a now toddler, a travel nurse while she was pregnant, while she was breastfeeding, and she had a unique experience during her labor as well. So she's going to share some of that. I hope y'all enjoy. All right, so I'm going to have you introduce yourself. Just tell us who you are, where you're from, what you do, all those things.
All right. Are you ready?
Yeah.
Okay, cool. So my name's Abeth, and I'm 29 now. I can't believe that because I started my career as like a baby nurse. Like I was like the youngest on the unit, and now I'm like, wait. What is going on? But
it happened real fast too.
I know, so fast. Yeah, so I'm a labor and delivery nurse. I started labor and delivery right out of college. So like I really didn't know anything else. I did like a brief kind of like intensive course. Like I had to have my RN license to do like the ICU, but that's because I was working as like a CNA tech role in the cardiothoracic ICU. And I just thought labor and delivery was going to be like way too hard to get into as a new grad.
Yeah.
So I was like, kept that in my back pocket. Like, okay, if I, don't get into labor and delivery, then I can go to the CTICU.
Right.
And I did that ICU course too to help me because the hospital I was applying to and the unit that I wanted to work in was high risk labor and delivery. So I was like, well, maybe some like ICU background will help me seem more appealing.
Girl.
Yeah. That seemed so long ago, but like not really that long ago. So I started working high-risk labor and delivery in 2016, and then I went to like just normal risk, like normal pregnancy, normal deliveries, and then I started travel nursing, and I've been travel nursing since 2019 before all the pandemic craziness happened.
Because life got real crazy real quick.
I know, yeah. It was good, and then the pandemic happened, and that seemed kind of just like it was crazy because we were still working. But I think a lot of people felt so isolated, but I don't know, I didn't really feel that isolated during that time. It was just kind of nice, like, because you're working so much, and I think people don't realize, like, as a nurse, you're tired, and it's like, I feel like I have, like, FOMO when other people are going out to do stuff, but, like, I'm so tired from working my shifts that, it just made me feel good, like, okay, everybody's at home.
Inside.
Yeah, everyone's inside. I'm not missing out on anything. I can pick up work, just work. And so that's kind of where I've been. And then now I'm working per diem at the hospital that I started working at. Like, I would even say, like, I feel like I knew so much back then, even, like, just working in high risk. But then even now, I was like, dang, I was still just such a baby nurse.
Right.
Like, yeah.
Like, knowing what you know now. Because I feel like I had the same experience. Because, like, the place that I worked at out here was super high risk, super low staff. And you were doing, like, some crazy stuff. You saw some stuff, but, like, you were a baby. And, like, you didn't know. I guess now you know how to maneuver around the system versus just
Yeah.
doing. You get what I'm saying?
Yes.
So
Yeah. Yeah. Or even some of like the crazy experiences that I saw, it was like that's your first time doing and seeing something so crazy that you're like, what did I just see? Or what just happened? I just know like this is not normal. And then now you're like, oh, I've seen this, or I've done this, or yeah.
I think
You do know how to maneuver your way. Yeah.
Yep. And then you don't get as, because I'm not really a super anxious person in most situations, but I do know, like, I used to be real anxious about D cells, and I realized when we were
Yes.
working in Washington, because they had the newer nurses, and they'll be like, "What do you think
Yeah.
about this? What do you?" I'd be like, "It's fine. Like, it's gonna be fine. Like, just go turn her.
Yes.
She all right."
I
And like,
know.
I'm like, I don't know when I got there.
I used to be that way too, and I was telling my friend, like, I feel like with every D cell, I was in the room,
Yes.
like, turning my patient. So it made for really long shifts because you were always in the room, always trying to find baby and readjust baby. And like, yeah, I'm sure, like, like high risk, it's like you're working with smaller gestations, so
Yeah.
it's harder to find sometimes, or, you have so many tricks. And I just used to be like, like how is like my preceptor so like competent or like calm or whatever, and now I'm like that person. But it doesn't negate, like, I feel like you should still be super concerned as a new nurse until you know that like that's okay,
right,
that
the reasoning behind not doing anything. Like, it's benign, it's gonna come back on, it's a reasoning behind it versus just, I don't want to go in the room. That is never okay.
Right. Yes, I know. It kills me. Like, I've been working with like some newer nurses that it's just like, I'm like, wait, like, just go in your room with your patient, try something. Like I'm not super concerned, but I also wouldn't be the one just like sitting there, especially just not, but it's hard too, because I know like a lot of places are short staffed, and it doesn't always like accommodate for newer nurses to get the training orientation. I think that maybe I did.
Yeah, I mean, it sucks because I think about too that, I mean, we're only it's gonna be 3 years out of the pandemic. So just think about like those nurses and residents and whoever else had to learn things virtually. And like, not only did they have to learn virtually, they didn't really get a good orientation. They like, dang, I'm just trying to figure this out.
Yeah, I know. So. Yeah, I feel bad for the nurses and residents, who had to learn, like, who had to do even sim. As much as I hated sim, but like, sim lab, like, okay, they didn't even get that because they weren't on campus because of the pandemic. Yeah.
Yep. All right.
But anyway, so that's kind of where I'm at right now. I'm in Washington State. And I'm a mom now. I think that's going to be.
And you weren't a mom when I met you?
I know. Yeah, that's so crazy too. Yeah.
Life
I wasn't a mom.
Girl.
I know. I know. I blink and I'm like, what?
Oh, man. All right. So I want to ask you, since you brought up you're in Washington State, we know the South and the West Coast have pretty big differences in the way things, I would say, happen in labor. Like, specifically for me, I'm going to say when I started my labor and delivery journey here in New Orleans, we had a lot of 39-week elective inductions, a lot of failure to progress at 2 centimeters with the water broken and ended up in primary sections. And that was just like, working on night shift is different because I know I have a little more leeway, but I feel like it was always the anxiety that you feel like you racing the clock. Like if you don't get this person to 7-8 centimeters before, a certain time, then you ended up in a section. It was just common practice. Like it was just, patients almost expected it. Like, okay, I know I'm coming for my induction, but if it don't work, I could just have a C-section. And I think that's something that really used to irritate me. I think that kind of made me want to start traveling and seeing, like, is this like this everywhere? Because this can't be okay. It didn't feel okay. And I know when I came to the West Coast, I'm not saying every place in the West Coast is, the same or, open like everywhere. But I feel like the vast majority of experiences I hear are way more open to allowing like your body to do what it's gonna do. Or if you're gonna have an induction and it's your first time and you only 2 centimeters, they're gonna give you 2 to 3 days to be induced because it's gonna take that long. But what's your experience, or what has been your experience with inductions and sections and stuff like that on that side of town?
I would say that it's unfortunate too, because your patients hear about these stories and they think that that's the norm. So then they come in and think that, that's our mission, is to get them delivered within a certain time frame. And that's not always the case. I do feel like it comes down to resources over here in the West Coast, at least being in like terms of if you're in a more rural area where there's not a lot of doctors and they still have to take patients like during the day and go, they're on a call for their patients at night. I do feel like there's a little bit of that in terms of like they're just tired compared to if you are delivering in like a bigger facility where they have their following day off post call.
Yeah.
But and then in terms of my experience for working in Colorado, I worked at a facility that had residents. Yeah. So I just felt like they were very patient, and I don't know if that's just because of like it's a teaching facility that they were very patient to go to a C-section. Like our strip had to look really bad. Yeah. Like the baby not tolerating labor to go for a section. But with that being said, I also don't know if everything was done the right way to like get that patient into labor, because you might have like a wrong cervical exam. Yeah. And with a resident, and then they would kind of, for me as a new nurse, I didn't really want to step on my resident's toes of like going behind the resident and like checking the cervix, but like the experienced nurses would do that, but at that time I didn't have that experience to be like, oh, let me check, and I for sure know you're not like 3 centimeters or whatever, like that was a learning curve for me. But at that point I kind of felt like it was like I took it on as the nurse so much, which now I feel like I don't really do that anymore, because I've like had the experience and tools to know that I've done everything I could as that patient's nurse to give them a vaginal delivery. But like back then I would be like, I would feel bad. Like I would feel like it was my fault. Like if I was pushing with a patient for 3 hours. Yeah. And like we ended up in a C-section. Right. And then I'm like, well, in hindsight now I'm like, dang, I wasn't really trying a whole bunch of different positions with my patient. But that's because I just didn't know. Right. Whereas now I do know kind of those tips and tricks.
And even you bring up a good point, because not to cut you off, but you bring up a good point, because at I try not to say the hospital names, but like when we were in Washington, I thought it was amazing that their nurses were educated on spinning babies and bundle birth nursing positions. Even within their Epic system, under position changes, they had so many different position changes. And I feel like that was like, I was just like, wow.
Because and they had resources all over the unit. Like, and you would go to your charge nurse, and your charge nurse could flip to a page and be like, well, did you try this? Or, let's get your position in this, you know, or let's get your patient in this position. Yeah. So that was, I would say that was different when I started traveling, to Seattle, where it's more, I think, known about that stuff, and then like California as well. I learned a lot in California too. For sure. But yeah, I think going back to like the rush of, you know, trying to get the patient delivered by the 7 a.m. or by whenever, it's like a lot of pressure as you as the nurse, and you don't, I feel like as a newer nurse, or even maybe experienced nurses too, that have maybe even lost their passion, I feel like, for labor and delivery, like they're just there to, you know, just to do the job, like, be a body, like they're not really there to make the difference. It's like it's lost in, I think, doing, okay, what can we do to get this patient progressing, and you can't just let a patient like lay in bed, and or even just turning side to side, like it's because that's what I used to do.
Me too, because I didn't know any different.
And now I feel so bad because really there's a lot that could have been done to just try. I don't know, but that's all hindsight now. I do know, though, that patients get really nervous about if their water breaks early and the time clock for that. You know, like, well, my water's been broken for so many hours. Like, does this mean I'm going to go for a C-section? And it doesn't necessarily mean that. No, like, there has to be a lot of other steps to, you know, or concerns of like your baby or yourself's heart rate, or, you know, signs that would have to go to a C-section. But I just feel bad because there's not enough time to educate people, and you don't really know what's going to happen because each person is different in labor. But like in the prenatal setting, there's not really enough time to explain this. And like I've said, like it's taken me 7 years of experience to, like, you know, get comfortable. To understand it.
It's true. And I think too, like with the water breaking thing specifically, like, I'm gonna tell you my, like, the best of the best and the worst. So like, I remember being in California the first time, because I went in 2018 first, and then I came back in 2020. But no, 2019. I think it was 2019. I don't remember. Either way, I remember when I went, and I had a patient call the unit and say, hey, my water broke. I'm not really contracting. Should I come in? And what I'm used to, oh yeah, your water broke immediately. Come in. Like, come in. And I remember calling, I don't remember if it was a midwife or a doctor on call. I don't remember who was on call. But I called to kind of ask them, like, what did they usually do? And they was like, you know, tell her, give it 12 hours. Go do some nipple stimulation. Go walk around. Go do this. Go do that. Give it 12 hours. If nothing happens, then come in. And I was like, oh, word? Like, that's what we doing? Okay, cool. And like, people typically come back in either full-blown contracting, or they just need a little help when they come in. And I thought that was amazing, because I didn't even know that was like an option, because people make it seem so much so like, okay, your water breaks, you're gonna get choreo, so we need to speed it up, or you're gonna deliver. And I'm like, I've seen like, you see like preterm ruptures that be ruptured for weeks that don't get choreo, and then you see somebody rupture for 2 hours and get choreo. So I'm like, you can't do that. You can't put people on a clock and you giving like false information. But then, like, the worst of the worst, which is why I don't like working day shifts, I swear it scarred me. I was working in Texas, and every morning before clinic, the one particular doctor, oh, child, would come in every morning, and she'll have all her inductions come in at like 6 in the morning, and they'll all be either one thick and high, like not laboring, not favorable, nothing, like not favorable for an induction at all, and come through and break everybody water. And if they were not delivered by 5 p.m., you might as well line them up for a section, because she gonna take them back to back, and her sections take 25 minutes. Like,
and see, I haven't worked at a place that's like that, but that would have me so, like, I don't know, that would just, as those patients' nurse too, like, that would give me just like no faith.
Yeah.
Like, what are we doing here? You know, it's like, okay, well, why do anything?
Exactly.
If she's gonna cut my patient anyway. Like, like I might as well just start preparing them for a section, because it's more traumatizing.
It is
just being like told, like, okay, you haven't made any change, like, let's go for a section. I think it being this
unnecessary. And I feel like I had got to the point there because I was just so frustrated. Because I mean, I feel like most people who have worked with me know I do not like going back and doing a section. I will put my patient on their head to do everything I gotta do to make sure we're not having a section. Not that I can't do it, because honestly, it's probably easier for me as the nurse. It's less I have to do. It's very standardized, you know, but it's just, to me, I'm just like, that's not why you came in here. And I don't feel like I'm giving you your best chance. And I would legit feel like I'm just, you know, busting my behind for like 8 to 9 hours in the shift, doing everything I can, sweating, flipping, doing all of these things just to make sure you don't get a section. I'm just like, that's not fair. It's just, I just don't feel like it's fair.
It's defeating to you as the nurse.
Yeah.
And for that patient.
I think I was doing a section. I did 2. I think I extended there once, but once I extended, I told them I'll only extend if they let me go on night shift. So them 13 weeks I was on day shifts, if I worked 3 shifts out the week, I did a section at least 2 of them shifts. Like, I was the section nurse. I always was in a section. I'm like, this is not why I do this. Like, I don't like it. It's ridiculous. But I feel like, I've worked in Texas, and I feel like it's very much so the same. The only reprieve I get is when I go to like the West Coast and work somewhere there, and I'm like, okay, maybe I'll have vaginal deliveries on this assignment.
I know. And it's so, no matter how you bring the baby into the world, but it feels so rewarding when you work so hard.
Or at least giving people the chance when it's I think it's more so when it's unnecessary. You know, I think that's what gets me the most, when it's unnecessary, because I'm the first person that I'll tell my patient, like, I am not super anxious about many things. If I come in and say I think you might need a section, you probably really need a section. Like, I think there are some cases where it's completely necessary. I think I have seen more cases than not that are completely unnecessary, and it's just not fair. Yeah. Because you kind of set them up. Yeah. You know, for future.
Which I think that's why there's this stigma of, like, you know, having C-sections. It's just because people are, like, traumatized from it. Yeah. And that's, like, also the stigma why people are, like, scared to have a birth in the hospital. Yeah. Being induced, you know, all the things, like, that you hear going around that make it hard to, like, say, like, no, there is good of having, you know, your birth in the hospital. It's just, it comes down to really being able to advocate for yourself and advocating for yourself, but also being open to hearing options and collaborating with the team and like your nurse and your provider, and then just like, I don't know, because of course we know that there are those times it's like, well, we need a section, and patients are really resistant to that, but it's like really needed. But you just have to be open. I think the birth experience, like your mind just has to be open to pivot and like discussion with your care team.
Agreed, because anything can happen and anything will happen. Yeah. And you're going to have to roll with the punches and figure it out.
But I mean, for the most part, at least on the West Coast, I feel that mostly providers are not like doing stuff maliciously,
Right, yeah.
At least that's where. Yeah.
I can agree.
Or on their own agenda. Yeah.
But I think, like you said earlier, y'all also have the resources. I feel like most of the places I've been on the West Coast have had in-house physicians, whereas a lot of the places I've worked down south, they all are private practice. They all are in clinic and have to leave clinic and come do deliveries or be at the hospital all night doing deliveries and still got to go to clinic in the morning. So, I mean, while I don't necessarily agree with the, all right, it's 5 o'clock. If she ain't delivered, she got to get a section because I got to go do this and I got to get up in the morning. But, you got to remember, too, people have a life. And it's like, you got to fix the system.
Yeah, and if the patient's been having, like, D-cells and, all night or whatever, but say the baby's still recovering or looks great in between. I mean, we don't have to get into all this, but some providers are like, I can't be at the bedside every time there's like a prolonged D-cell and we're needing to do, X, Y, and Z. And like, it just might be better to do it. But it's because they also have to do, clinic the next day, which is so hard.
And they have lives, that's the other thing. They have lives. And I think too, when I went back to school, I felt like, while I want to be a provider, like even when I did my interviews, like, cause I've interviewed for a few midwife jobs or whatever in the past. And they would ask me like, what's important to me in a job? And I was like, work-life balance, because my job will not be my life. Like I am not going to be on call 24/7. That's how people get burned out. And that's how people get jaded in their profession. And I don't ever want to be like that. I never want to be like that.
And they don't do what's best for the patient in that scenario because they're just so, like, I think it's just like sometimes they're just so over it.
Which I get. I mean, I get it. I get both sides. But at the end of the day, it's about the patient. It's honestly not about you. And you're going to have to find some backup because that ain't going to cut it.
Right. It's good that you said that. I wouldn't have thought about that in a job interview.
Yeah. Like, I mean, and it's because they asked me. Yeah. And I think, too, it's because I had, like, I'm so thankful for the preceptor that I had in my midwifery program because we were very similar. Like, I love to travel. Sis has 4 kids and be going to Germany like every year. Like it's like a thing, and she loves to travel, and most of her group does not take time off to travel. And she was like, Sarah, like, I know you love to travel, and I don't want you to think you have to give that up for a job. You have vacation time and you can use it. Like, don't ever get on a job and let them make your job your life, because it's not your life. Like, you still gotta live your life. You gotta, if you're gonna have a family outside of work, you gotta sometimes go for your family. You gotta be with your family. You can't always be at the hospital. So but so let's switch gears and talk about your experience with pregnancy and labor, and how your experience went.
Yeah, so I guess myself being pregnant, I like knowing what I know, it just like was not good for me. Like, I just feel like I was, over analyzing everything, or not necessarily overanalyzing. I wasn't actually overanalyzing stuff. It was always the what if.
Right.
I was always thinking about the what if of like my pregnancy, and I don't know, I think it just started because I've seen so much like scary stuff, but like it was even started with the like genetic testing.
Oh yeah.
I knew Jerron and I like wanted to do the initial genetic testing, and I don't know, it was kind of even like, well, if something doesn't come back like reassuring, like I feel like, which is so controversial, but I think I made that decision in nursing school when we watched like a series of videos of people who had children with that they would have said like if they would have known in the genetic testing, like they don't know if they would follow through with that pregnancy. So I think from then, like I was kind of really guarded about my pregnancy, and then once I got the genetic testing back, I was like, okay, I can take a breath. Like I think I'm a little, like I think I'm excited. And then but it was always just like, I don't know, I felt like I knew my risk factors being African American, you know, the whole BMI thing, which I think is super, that was really rough in my pregnancy. Like knowing that, you know, that criteria puts you in a higher risk category and stuff. But anyway, I just felt like I get it that doctors have, and midwives, it's like there is the guidelines, but I don't know, I feel like you also have to look at the person and how they live their life. Like I don't intentionally like not work out, or I don't know, it just, I feel like it kind of set me in a depression of like, well, people aren't really believing that I'm gonna eat healthy, or that I do eat healthy, or that I do exercise, so it's like, why do it kind of thing. And then I don't know, I was just in this cycle of like depression and like bad thoughts, and I don't know, in my pregnancy. But and
that's not okay. I feel like that being like, I get it, but at the same time, like what I tell people when I talk about like the whole BMI thing, because I mean, you're supposed to say it, but I'm like, the BMI chart is a standardized chart that is probably not based off anybody who is built like, live like you and me. So take it with a grain of salt, eat healthy, do what you can. You know what I'm saying? Because you got to be realistic. Everybody's life ain't set up to do whatever, because honestly, I know I work out like 5 times a week and I do all of this other stuff. I'm still classified as overweight, and I'm like, who came up with this? Because if I actually weighed what it say I should weigh, I would look sickly. So I personally don't even agree with it. But sorry, go ahead, continue.
No, I know, it's just like, that's what was frustrating during my pregnancy. I just felt like I couldn't enjoy it. Maybe I was like embarrassed. I just feel like it's like, oh, I didn't necessarily look the way that, you know, I feel like pregnant people look, or like, what if I didn't look pregnant, or, you know, just all the things. And then on top of that, knowing, you know, what could happen in my pregnancy just based off of my experience. So anyway, it was just like a whole issue. Like I was nervous about gestational diabetes, and everyone seemed to be so nervous about me getting gestational diabetes during my pregnancy. And like, I just wish it was more like, hey, this could happen, and like, this is what we would do about it.
Right.
And not just, I don't know. Yeah. Make it such a big deal. But so then anyway, that, I would say being pregnant wasn't super great, but I did end up developing gestational hypertension at 39 weeks. So that put me, you know, at they wanted to induce me for that, which I was so like torn up about. Like I was like, I didn't want an induction.
Right.
You know, you want all the right things that your body is supposed to do. But I think it happened the way it was supposed to, because like I remember that Saturday, which I don't know if I told you this, but the Saturday or Sunday before my my midwife appointment, I think my midwife appointment was on a Tuesday. And I had gone to see Chastity, and anytime I traveled, I would really swell up bad. But I just knew like it was different. Like normally I would swell up, but it would go down, and this time it like wasn't going down, and I had a little bit of a like just mild range blood pressure before. But that's the other thing. It's like, yeah, my blood pressures were like, it was still normal. Like, why did we need to make it a big deal like that previous week, you know? Like, I just kept being like, yeah, but it's normal, you know? But maybe, I don't know, maybe my midwife has seen it more than I have, the progression of gestational hypertension and preeclampsia before, you know?
I think people are also very more, like, what word do I want to use? Maybe aware, because you know, like the recent studies about Black women and preeclampsia and all these complications and all that stuff, and I feel like people are being a lot more vigilant about it. And I'm also gonna say I feel like I have seen so much more preeclampsia since COVID too, though. Like I feel like it's been like a thing. I feel like it's been apparent, but yeah.
So I do feel like my midwife too, on that note, was very, like you said, aware and like vigilant of the health disparities that Black women face in childbirth. And she like really didn't want that to be, she did not want anything bad to happen to me.
Right.
So, but then again, on hindsight, I was just like, I just feel like I'm under such a microscope,
right.
You know?
Yeah.
I don't know. But, anyway, I got gestational hypertension, so then that was like a long day, and I had even had a headache like the night before, or a couple days that I was having to take Tylenol for, and I had swelling on like my abdomen, so like I just kind of had a feeling like this isn't going to be good.
Yeah. So
I went into my appointment on that Tuesday at 39 weeks, and it was like really high. My blood pressures were really high. So yeah, they admitted me to labor.
Wait, so you flew to Georgia at 38 weeks?
No.
Oh.
Chastity was doing a travel assignment in Seattle.
I was going to say, wait a minute.
No, I had driven to Seattle, which is like 2.5 hours.
Okay.
And then another 2.5 hours back. So I probably spent like 5 hours in the car. I mean, but the swelling like wasn't going down this time.
Right. Okay.
Yeah. And then when I was there at the hospital, and my blood pressures were, anytime I would like talk, because I was like reunited with some coworkers that I hadn't worked with or seen since like 2019.
Yeah.
And I would just get really excited and my blood pressures would go up.
Oh,
so
no.
My midwife was like, okay, well, I'm going to let the obstetrician who's on call know you're here and kind of your situation and have him come lay eyes on you. And I didn't realize this, but, because I always thought like preeclampsia and MAG was started, I guess, if like you had elevated labs or like protein in your urine. Like I didn't realize that my blood pressures would be enough to like start me down that road.
I feel like it depends on the hospital. I feel like I've worked at different hospitals where I'm like, okay, this is happening. Are we starting MAG? And they're like, well, no, we got to do this first. Or like they have somebody that hit the door with high blood pressure and they start them on MAG. It's like, I think it really depends on the policy, and that's the issue. That needs to be standardized too. But it definitely,
so I don't know. I guess I'm still unclear of like what the evidence actually is and what the doctors should be doing. But yeah, he was like, well, basically, and this too, I didn't realize that being treated for high blood pressures, like in terms of, even if I wasn't on mag, like let's try some more Betalol,
right.
Or whatever, nifedipine, what you would do for someone with gestational hypertension.
Right.
I guess in the hospital setting, I didn't realize that would risk me out of midwifery care.
Yeah.
So that kind of gave me a lot of anxiety too. I was like, wait, like, I've been doing this and I've never had that happen.
Right.
Or I just maybe haven't paid attention, or it hasn't been, I don't know, like, I don't know, maybe I just missed it. I have no idea. But I wasn't like if you guys give me a dose of Betalol, like I didn't realize that would risk me out of midwifery care, which I just didn't want, because I do feel like obstetricians are a little bit less patient. I mean, you can get some really patient, but I don't know. I just felt like they're not as, I don't know. I wanted the midwife experience.
Right.
And I really trusted my midwife. And I think it's to say, like, any patient that, does go to their midwives and has to go to the obstetrician for, like, a C-section or for anything else, it's kind of heartbreaking to the patient, because they're like, well, I built all this trust with my midwife and this team for the last, 9 months, or, 30 weeks.
And you expect to see them. Like, you expect them to be there. You've been waiting for that. So.
Yeah, and it's hard too, like, even when they do handoff care, like, it's not very common that you see your midwife
come back,
very much anymore. Yeah, like, not even to check on you, really. It's not, they're kind of like, okay, we're done, they have to move on. So, anyway, like, it's not, like, still collaborative care.
Right.
It's, like, really now you're the doctor's patient. So, anyway.
That's sucky.
Yeah, but anyway, so I kind of would just, here's a tip out there, if you have high blood pressure, I would just, like, count down from 10, and I, like, wouldn't talk, and I would just breathe slowly, and my blood pressures would, like, come back down to normal. So I was never had to be treated with Betalol or put on magnesium for my high blood pressures, which was good.
That's good. Yeah, because they have a lot of people that come in the clinic. I think now that I'm in a clinic right now, and I see, like, people legit walk up and immediately sit in the chair and run a blood pressure, and they be like, oh, it's elevated. I'm like, she's 9 months pregnant. You have her walking all the way over here. She had to walk across the parking lot and come up here to come to the clinic, and you immediately take her blood pressure. My blood pressure would be high. Like, I don't know. But
and even being in the right position, like not crossing your feet and like sitting down, arm heart level, like all those things.
Ooh, let me put a PSA in here real quick. If your provider, if you have, I'm just putting this out here because this really, I've seen it in the past 2 assignments I've had, and it really irritates my soul. If you know that you have elevated blood pressures, high blood pressure, whatever the case may be, and your provider tell you when you go to the hospital or you go to the doctor's office, they have to take your blood pressure laying down while you're on your left side, that is incorrect. You do not live your life laying down on your left side. Whatever your blood pressure is when you sitting here, that's what it is. That left side stuff, it's going to make it lower, but that's not what it's going to be when you sit up. Like, when I tell you that irritates my soul, don't have these people coming in here trying to get false readings just so I don't have to send them to the hospital. Like, it's not okay. They're going to go home. Their pressure going to be elevated. They're going to have a stroke. Like, no. Like, that's not okay. So that's my PSA for the day. Don't do that.
There's that, and also, I will say, too, if you have a history of high blood pressure or, like, white coat syndrome or anything, like, now I have it. Like, if you've had a baby before and, like, you've had high blood pressure and just, like, the trauma and, like, feeling of the blood pressure cuff going on, going like blowing up or putting the blood pressure cuff on, it like freaks you out. Then like it's almost like if they do have one of those like automatic machines, it's almost better just to be like, hey, I have like a history of, because I don't know, it just gives you back that feeling of like, great, this is something more than I thought it was going to be.
Right.
And like if you could do like an automatic cycle without them in the room, like 5 minutes after you've sat down, like, it would be so much better. And also manual blood pressures for me, I feel like are better too, because I feel like once I feel the blood pressure cuff retighten, I'm like, great,
it's going up.
High,
yep.
You know? Yeah. Oh, I don't know, but that's an after the fact. But if you have had the experience like of preeclampsia in your pregnancy or gestational hypertension in your pregnancy, like just do some breathing and deep breaths and like tell them to give you time before they take your blood pressure. Yeah.
I always tell people like, let me know. Like now that I'm at the clinic, I have people, I see they chart and I'm like, oh, they have a history of elevated pressures or white coat syndrome. Oh, I'm gonna bring you in there and we gonna chit chat first. We gonna talk, we gonna be chilling. Like you can sit there and then I'll take your pressure, because I'm not taking this because you don't know me. For me to just sit there and just start taking your pressure and just go to the computer, like my nerves will be bad too. No, we can chit chat a little bit and then we'll take it.
And because like weight was such a big deal to me, like I was going into my prenatal clinics like freaking out about what my weight was going to be or what they were going to say about my weight. Like it's probably not a good time to take my blood pressure after you weigh me.
Exactly. Either. That's true.
Like
that's very, very
that
true.
Just because I felt like it was I always got my blood pressure taken after my weight, and I was so disappointed about my weight and like what are gonna say. But however, I will say that probably a lot of the weight that I gained towards the end was fluid because I was getting
hypertension,
sick or whatever. Yeah.
So that's not a good thing, but at least you can kind of see like the correlation.
Yeah. But it's just hard. Anyway, so that was kind of like my hospital like induction part. With I was like, I think they were trying to figure out what they were going to do with me because my blood pressures were so high, and then it was freaking me out that maybe I would have to be transferred to the OBs. But anyway, that was fine. I kind of knew what I wanted going into my induction because I've worked in the field for so long. But basically, I wanted like Cervidil, and I wanted to sleep, and I wanted my cervix to get really ripe overnight, and then like kind of go from there. But that didn't really happen for me. So we did Cervidil, and which in hindsight now, I think I love it. I love a Cervidil induction as a nurse. And then I also like it as a patient.
Okay.
But it's in hindsight, it's really expensive.
It's expensive. And it's you paying for the medicine and you paying for like 12 hours of you sleeping. Because you're just sitting there for 12 hours.
Right. Right, but I think that's why some providers don't do Cervidil. That's why some hospitals don't have Cervidil. And so as a patient, I don't really think you don't need Cervidil. Yeah. I feel like I was also the one patient that like it did nothing for.
Oh no.
Compared to like all the other patients that I've had that have had Cervidil.
Yeah, I've had people deliver on Cervidil.
Yeah. I was like the anomaly, and I feel like it didn't do anything. It got me to like a fingertip, and my midwife felt confident to place a balloon. Okay. To dilate.
How was the balloon experience for you?
Also, for me, everything was so uncomfortable. Like the cervical exams and the balloon placement. Like I never thought like I would be the patient like climbing up the bed.
Yeah. Yeah.
I feel like it took everything in me. So it really humbled me being the patient, from like being the nurse in the situation. But yeah, because it really took everything in me, like not to like climb up the bed. Like, holy heck, this totally hurts. Like, it's so uncomfortable. But I was super uncomfortable with the IUD placement. So that's kind of what I kept referring it back to, of like, it just feels like that, like so terrible. And I think some people handle the IUD placement really well, and then some people also handle cervical exams really well, and some people handle the balloon really well. Like, they'll be walking around like nothing happened, and I was like so uncomfortable. I needed fentanyl. I needed a fan on me. Like, I just wanted to lay on my side in bed and not move. And so I didn't move for like 5 hours.
Okay.
I didn't even get up to go to the bathroom because I was like, I don't want to sit on the balloon, nothing. And also a concern that happened is my water had broken on insertion of the balloon. So that can kind of like pose a risk. I know we talked about like starting the clock, but you just really don't want to get choreo when your water has broken so early on in the process. So infection was like a huge thing. And other places that I've worked, if your water breaks, like when you have the balloon in, they automatically deflate the balloon and move to the next induction method. But I guess the policy at this hospital was that on insertion of the balloon, it's okay if the water breaks.
Okay.
I guess. I don't know.
Yeah. I only had that happen one time, and that was in California, and they just took it out. No, I'm lying. They kept it in because they said, what did they say? Like, we looked at the package, and it said something like it wasn't sufficient evidence to say you can or can't use it, so they don't recommend it. But it's not that they also don't, it's also like they don't recommend that you not keep it in, but they like also don't recommend it that you keep it in. So I think they just decided to keep it in just based off of that. But that's the only time that's ever happened.
On the safe side.
Yeah.
Right. Yeah. Yeah. And I had never, I feel like I couldn't recall a time that it happened on insertion. But I remember in Colorado, my preceptor getting so upset because the residents wanted to keep the balloon in even though my patient's water had broken.
Gotcha.
Like, this was like, had been in, her water broke, and the resident was like, no, we still need to keep, like, we're going to keep it in until it comes out. And like, my preceptor was like, no, this increases her risk for infection. Like, here's the policy, you know, very much like advocating for our patient, which I think was a good example. Yeah. But for me, I think too, at the time, I don't even know if I second guessed it at that time. Like, even knowing what I knew about the infection, I don't even think I second guessed it at that point. Because I didn't even ask my nurse about it till it had come out and my night shift nurse was on. And I was like, my balloon was in all day and my water was broken. And they said, that it's based on if it happens when it's being inserted or when it's already in, type of thing. So I was like, anyway, I think in so much pain that
it wasn't even that you didn't even care.
yeah, I didn't even care. But so then the balloon was in. I didn't move for 5 hours. And then every time my nurse would try to apply tension, I was like, no, I need fentanyl before we apply tension.
Yeah.
And so then I had her give me fentanyl one time, and I was like, okay, let's pull it really tight. And really, I didn't feel hardly anything.
Oh, wow.
So I pulled it. Yeah, I pulled the balloon like really tight, and I was like, okay, now you tape it down. My birth experience was very like collaborative. Like, I feel like I was telling them how to put my blood pressure cuff on, like, you know, what positions to change me in, all this. But that didn't really even start happening till I was
later,
like further along. But yeah, because I was like, oh, I'm the type of nurse to be like, oh, like be up walking, try the rocking chair, even with the balloon in. And then once it was my turn, I was like, oh no, we are not walking. I am not doing none of that.
It gave you a different appreciation, huh?
Yes. Yeah. Like, if you want to lay in bed and take the fentanyl, like, lay in bed and take the fentanyl, you know? Like,
especially early on. Like, early on, yeah. I think it's fine.
Yeah, so, yeah. So then so then she applied tension one more time, and it, like, came out. And I was like, see, that's what it should feel like when it's on its way out. Like, oh, it didn't feel like it was hurting or anything. So it came out, and then I was like a different person. Granted, all my contractions stopped. Like, no more contractions. I felt great though. I took a shower, I ate dinner, like, I was living my best life. And then they decided to do, also with the balloon, they did side attack too.
Okay. You know, side attack like 25 cents or something like that?
Yeah, it's super cheap, right?
Yeah. And I think Cervidil is like $1,200 or some foolishness.
Yeah, it was $1,200. Yeah. Yep. Yeah. I don't know if it made like that much of a difference for what I had to pay like out of pocket. But
yeah.
I don't know. I guess if anyone is in that predicament where you might have to pay more or whatever,
then you choose the cheaper.
Yeah.
For sure. For sure.
Yeah. Ideally, what I had wanted to do, if I would have needed an induction and not had to been in the hospital for like, you know, a while, is like, if I was going to do like a 40-week induction, because my midwife really didn't want me to go past 40 weeks. At that time, we had talked about the plan would have been to place the balloon in the office and then me go home.
You see, they did that in California too. That was my first time hearing about that.
Yeah, we had done it in Colorado. And then when I asked my midwife about it, she's like, oh, actually, we just got approved for the policy to start doing that.
Okay.
And I think they started doing that because of COVID. That's kind of what, like, propelled that change to be made. So I had wanted to just have the balloon placed and then go home, labor at home, come back when it fell out or whatever, or after, or when it's supposed to come out, 12 hours.
Right.
But my husband was like, I can't believe you had wanted to do this at home. I was like, oh no. If we did this at home, remember in California when there was like if you were having a prolonged decel, you would cut the balloon and drain it.
Yeah.
Did you ever do that in California? Instead of doing it with a syringe, I was like, no. If we were doing this at home, I would have cut it, drained it, and we would have been back at the hospital. Like, I need to try something else
because this is not cutting it.
Yeah, and I was like, or I wouldn't have even made it to the car. Like, I couldn't sit up. Sarah, like, I couldn't sit. Like, there's no way I could have been in the car, or I would have had to be, like, laying in the back seat in the car. And he's all, I would have been that, this might be TMI, but after I had it placed, like, I had this huge sensation that I had to go to the bathroom, which I did have to go. I think it's just like everything that's happening down there.
And it's right there.
I had to go. Yeah, and so I went to the bathroom, and I know my nurse was coming in, so I told him, you know, if my nurse comes in, can you tell her I'm like going to the bathroom? And he's like, yeah, but are you really going? Because you know, me as a labor nurse, he's like, I've heard you say when people have to go to the bathroom, like the baby's coming. And I was like, no, I really do have to go. Like, this is, this is real.
Good for him for being a good labor husband.
Yeah. And he was like, well, if I can't believe you wanted to do this at home. Like, if we were doing this at home, I would have called 911, like, my wife is having a baby, And I was like, I would have been so embarrassed. Like, having the ambulance there to come pick me up, and I'm not even dilated.
Right,
I'm 1
right.
centimeter.
Oh
He's like,
my
I was
God.
just, like, you were in so much pain, and you were so uncomfortable, and
Mm-hmm.
he said you had to go to the bathroom. He's like, I know you. You would have tried to have the baby at home, so I'm not gonna have that. I was just like, oh my gosh. Twisted world, thank goodness I got gestational hypertension, so I wouldn't have to go through that. Embarrassed.
Oh my God, that's crazy.
Man.
I mean, people
So
say
bad.
it's bad. I've had people that say like it's cake, like it's not that bad. You have the people that get it in the office and walk around and go do stuff throughout the day and then come in at 12 hours. But then you have them people that's like, yeah, take it out right now.
Yeah. Well, I remember too in Colorado, which maybe it's because your cervix just isn't as ripe. I don't
Right.
know,
That's what
but
I was thinking
it's
too.
like maybe because I know we had some early like obviously they were early or high risk or something, like, and they did not tolerate it very well either, and they would even give epidurals.
Yeah, I seen that too. Yep.
Yep. So I don't know. I just thought I was stronger than
Girl,
than I was.
stop. Don't even use that terminology.
Or like I just thought my pain tolerance was like higher. Like
Yeah.
I don't know. I like to like have like really intense massages that I think people would say are painful. Like I just thought I had a higher pain tolerance than I did.
I don't think we
Anyway,
can prepare for that type of, it's not something like,
no.
if you run into something and hit your knee, like, okay, that's going to hurt, but like, I kind of know what that pain is like. I'm going to be all right. You have no clue what that's going to be like.
No, you have no clue what it's going to be like, and you have no idea how long it's going to last or anything. So that was my whole thing. Is like especially with when they were pulling tension, like I would just get this terrible cramp, and I'm like, I just don't know when it's going to let up, and that's what was like messing with my mind, Yeah. But anyway, got through that, had a delightful dinner, and then I was started on Pitocin, and really I wasn't even feeling really that uncomfortable with the Pitocin. But then I must have had a 4-bag or something because my second bag of water broke. And then that's kind of where I got the pain that I think most people feel like when they go into labor after their water breaks. And it's because, then I was starting to feel the contractions. And I remember just telling my nurse, because like the balloon had come out, you can kind of assume that you're about 3 centimeters, 3 to 4 centimeters. And I had wanted to make it like a little bit further before getting the epidural, but the balloon had come out and then my water broke. And there I was like, I just don't want it to get as bad as how it felt with the balloon. And she's like, well, it's only going to get worse. Right. So, you might as well get the epidural. And I was like, I was so grateful that she told me that because, there is where I definitely wanted the epidural. And Drun's parents had flown in, or Drun's dad had flown in that day. Everyone thought like the baby on his side of the family, or I don't know, maybe everyone, I don't know. I thought he thought the baby was going to come like that Cervidil night. Yeah. And when it didn't, I think people just thought it was going to happen so much quicker, which I think is what people all around the world think, or all around the country think. Yeah. And it's a slow process when you're trying to go from like 0 to 100. Yep. It takes time. Yeah. Especially when you haven't had a baby before. Yep. And so anyway, his dad had flown in, I think thinking that the baby would be born, but I think everyone thought the baby was coming that first night. And so he was out late with his parents. He, I think, returned back to the hospital at like 11 p.m. that night.
Mm-hmm.
And by then I was contracting and I was starting to get more uncomfortable. And then he had tried to hook up like the Fire Stick, and I also thought I was never gonna have the partner that comes with like the Xbox and all that, but nope, that was my husband. Which it doesn't make me like, now I'm like, whatever, it's a long process. Now I get it, but at the time I was like mortified, like, you are embarrassing me in my field. Like, we make fun, not that we make fun of, we do. Of the people that come with their, and they're always trying to ask the nurse, like, how does the remote work? And how do we get the channel changed? And I'm like, I don't know. I'm not an IT. Exactly. I'm not an engineer.
We can figure it out together.
Yeah. But it doesn't make now, and when we were working in Seattle, I had a patient. He already knew, like, that nurses do not know how to work remote, so he came with his own TV. And that made me feel a little bit better about my husband. Yeah, but I think probably for the next baby, I think my husband will come with his own TV. We had some issues with the whole Fire Stick thing. But anyway, so he was exhausted. He came at 11, and everyone had been asking him all day, like, did you get sleep? You should be sleeping. Like, get your sleep. And he's like, I don't understand why people are so concerned about my sleep. I'm like, because it gets real, and then you don't
sleep. Exactly.
Yeah. And so then he was like, he come back, and I was in pain, so I think he was trying to stay awake, but he was really tired. And so he started playing his Xbox. And I was just like, this is not the time to start to play the Xbox. Like, this is, of all the time, this right now is not the time.
That is hilarious. Yeah. Oh my god.
Oh, it kills me. It just is so embarrassing. But anyway, he's like, okay. So then that's when my nurse was like, had the talk with me, like, it's okay to get your epidural. So I was like, okay, I'm gonna get the epidural. I got my epidural, and that's another thing that I had wanted, is I wanted combined spinal epidural, because I wanted to be out of pain immediately.
Yeah.
But my anesthesiologist was like, well, I normally don't do those. So, I was like, you know what? I'm not in a terrible amount of pain. Right. I'll be fine. Right. I don't need it gone immediately, but I just wanted the luxury,
Yeah.
Maybe it was, I don't know. I just see how they work, and they work so well at first. Like, the patient's, like, out of pain before you
even lay them down. Yeah.
Yeah. But yeah, he didn't. But anyway, I'm grateful because he did a phenomenal epidural for me. And as I think I'm getting ready to, like, lay down and getting repositioned and comfortable, Jerome sits on the couch, and he falls, like, he was tired. He fell asleep sitting up. Like,
poor
by
thing.
the time the anesthesiologist, like, left the room.
Oh, poor thing.
I know. I feel bad for yelling at him about the Xbox, but anyway. So then I would say over the night they were trying to just get my contractions more regular. I was on the wireless Novi monitor.
Oh, nice.
Have you used those?
Yeah.
I feel like it's a hit or miss.
It is.
For me.
Everywhere.
Typically it doesn't work. Yeah. Typically it doesn't work for me, but on me, it was actually working really well. So I was like, as long as we can keep the Novi on going good, as long as it's working, I'll keep it on, because it allowed me mobility.
Yeah.
And to move and that first night with the Cervidil, I had the regular monitor on,
Mm-hmm.
and I think, which I understand with patients, I think I'm just so self-conscious about, like, my body image and my weight and,
Mm-hmm.
like, inconveniencing nurses, and I didn't want to inconvenience anyone, and anyway, I didn't even really get the best sleep anyway,
Right.
because
Mm-hmm.
I could hear when the baby's heart rate would drop.
Yeah.
And I'm like, well, I gotta adjust it. Like, I was just trying to be
your nurse
like,
instead of being the patient.
yeah.
Mm-hmm.
Yeah. So the Novi was really nice because that it was working, and then I had the mobility, which is like another, I think, testament to like what makes a good labor experience is being able to like move. And it's not even just like move, like get out of bed, but just even turning a position without inconveniencing someone. Because I feel like patients either stay in a position for too long that they're uncomfortable in because they don't want to inconvenience us to come into their room. And I'm like, no, just move. Like, if you're uncomfortable, just move.
And if I have to move the monitor, I'll move it. Like, no biggie.
Yeah. Mm-hmm. Mm-hmm. Yeah. But I think as a new nurse, I was like a little bit, I wasn't like, it's hard when you're in the room all night adjusting the monitor and the patient doesn't really get that much sleep. But having the wireless monitors, I loved those monitors that we had in Seattle and in California.
They're amazing. They really are.
Yeah. Yeah, those ones are the best. But the Novi worked for myself. It's always worth a try, I think. Because you never know when it's going to work and not going to work.
Right.
Yeah, but so then they were titrating the Pitocin, and I guess the thing with the Novi is there's a little bit of a lag, so sometimes it's hard to tell what the baby's heart rate is doing as a nurse.
Yeah. Mm-hmm.
If you're like, is it having lates? Is it the Novi? Is it tracing right? Is it actually just tracing like some irritability? Like, what are their contractions? So I think my nurse was like a little bit more conservative because we didn't know what my baby's heart rate was doing at the time.
Yeah.
At some points it kind of looked like there was lates, and which I guess with anesthesia, you know, I also went from having like a very like high baseline of blood pressures to now having anesthesia, which brings blood pressures down. Like, you know, there is that concern of like, well, maybe the baby is like reacting to the change of environment or whatever. So they were a little bit conservative. So then when my midwife came on the next morning, which now we're on, I went on Tuesday night. We're on Thursday day.
Okay.
My midwife, she wanted to put an internal IUPC in.
To track your contraction strength.
Yeah, to track my contractions better. But then I knew that, okay, now I can't have the Novi on.
Right.
Because you can't use one and then use another. So then I didn't necessarily, like, I was really disappointed. I really didn't want internals because I knew that increased my risk of infection and increased my risk of infection, and because like my water had already been broken for so long.
Right.
Like I was just I really didn't want internals, but then it kind of made sense because it's like, okay, well, if we do have to go for a C-section, or like if anyone's looking, we can prove like, okay, I wasn't in adequate labor.
Right, exactly.
I wasn't having adequate contractions.
Right,
so like it kind of benefits you to be like, to keep pursuing a vaginal birth if you can prove like, well, we haven't had adequate contractions yet type of thing. And if, of course, the baby would tolerate what we were trying to do. Right. So anyway, I kind of was like, okay, I guess we'll do internals. But and initially she wasn't going to do an FSE. She just wanted an IUPC. But because of that first night, how I knew it was with the heart rate. Yeah. And me just wanting to like be as free as I could, I asked her to do an FSE. That way
It's just
I didn't have to worry about the externals. Right. Yeah, which I think is good. And I think, like, once again, going back to when I was a new nurse, is I really thought, like, with internals, you couldn't move patients as much. But, like, I don't know, now that I have experience, like, you can absolutely do different positions with patients. And I had even had a patient who had wanted to have an unmedicated birth, but it was really hard to trace the baby, and because she was up moving on the birthing ball, all these things, and I just feel like the provider that I was working with would have maybe been inclined to give her a C-section. And so I had talked to my patient. I was like, hey, maybe we should do internals. And that was the first time, actually, my charge nurse had recommended it. Like, hey, you should see if she'd be open to doing internal monitoring. Yeah. That way we can tell what's going on. Right. And the provider agreed to it. The patient agreed to it. And she was able to, still have an unmedicated delivery. Right. But she had internals in, but she could still, like, get up and move around, which was great. That's good. Yeah. That's so I think that's actually a good alternative for people who maybe want to be more active. I don't know. But, like, yes, it increases your risk of infection, but, like, you can move more. So hopefully you'll be able to deliver your baby how you want to versus having a seat. Like, you'll be able to do more, make more progress instead of having to, like, sit in bed and, like, maybe you'll be able to do stuff to get your baby in a better position. Exactly. Faster. Yep. Before you get an infection from, the internals. And you're just, I don't know, you'll make more progress that way. So before I went traveling, I was kind of against internals, and I would kind of, I don't know, just be like, but there's benefits to it. Yeah, there's a lot of benefits for sure. I agree. Completely agree. And so then that whole day Thursday, I was like turning myself every hour, and it's just because like I have the knowledge, I think, of like what would be the best position. But I guess my advice to patients would be like, how do you lay in bed? I lay with my leg up, I'm supported by pillows. Like, you don't just lay on your side. Right. Like, I don't know. I don't sleep like a zombie. I'm probably like a crazy sleeper. But like, I'm not in just one position all night. Like I just moved to feel like what I felt like would feel good. So I had my leg up in like a runner's position a lot. I used the peanut ball, and I think in terms of like what you can control as the patient is advocating for your movement. Yep. And even searching, like I don't know if it's something that has to be paid for, but like that bundle birth nurses card, the little thing that they had in Washington, is so informational. Like, even if like people can just Google it and just see like, okay, like just even having the basic knowledge of how dilated you are and where your baby is in the pelvis, you can look on there and just be like, okay, well, to get my baby engaged, or to get my baby to come down, or, just to know how you should move. But I feel like even as labor nurses, most labor nurses don't even think about moving people in the way that they're moving the baby to fit into the pelvis. You know what I'm saying? Like, you don't even think of it like that. But I feel like it's super helpful if you have a patient who has done just even the smallest amount of research and be like, maybe I could try this position because I was doing this, and maybe this isn't conducive to whatever position the baby in. Maybe we should try this. And sometimes a nurse might be like, you know what, that's a good idea. Let's try that. Yeah. I know. Yeah, exactly. And I think, if you just move to like what feels good, I think a lot of people are like nervous to like lay on their belly, but like try to get, really side lying. Like it feels like you're going to be laying on your belly, but like do it, it helps to get baby in a better position. You do, I think, have to pay for that bundled birth nurses, but Spinning Babies has a lot of free resources on their Instagram and on their website. So I've looked up pictures from that. So yeah, you could
look at them too.
Nurses.
And they're both great.
Yeah, you do have to pay.
They're both great resources. And honestly, I feel like with most things, you can always like YouTube and I guess nowadays TikTok stuff, and you'll find what you need to find. I'm more than sure.
Yeah, exactly. Yeah, but that I think is the best thing that you can do as the patient for advocating for yourself is like just advocate for movement. Like and the other thing that my nurse said that was great about getting the epidural, because I think a lot of patients are nervous about the epidural that it'll kind of lead to C-section, is my nurse did say, she's like, I don't care about early epidurals. Like, I'm still going to move you to get you into different positions.
Right.
And that was kind of reassuring to me. So I try to reiterate that with my patients too. Like, we're still going to move in ways to get your baby in a good position for you to deliver. And you can still move when you're pushing too in different positions. Because I think a lot of patients are nervous to only be on their back when they're pushing. And it's like, no, there's other options. I think too, as a newer nurse, I was nervous about getting my patients in a position, or it was a little bit more difficult if they had a really dense epidural.
Right.
But I'm realizing now that even if they have a dense epidural, like, you can still do a lot.
You can still do a lot. Even if it's just sideline pushing, you can do that.
Yeah. And if you have the staff or tech to have you help move the patient in a position that's better. I think as a newer nurse, I didn't realize that, and I just didn't know. Also, patients with that are a little bit larger, like sometimes I feel like they don't have as much room to move. But even if you can utilize, off the bed stuff, like having their leg hang over the bed, or even utilizing hands and knees, or breaking down the bed and supporting their knees, a whole bunch of different things that me as a new nurse didn't do with those type of patients. But I'm like, nope, you can still even put the peanut ball in a position and move their legs just a little bit. Or I learned this at a hospital that I worked at, where they would do kind of like a modified Wilchers, where they would put a rolled up towel underneath their back, so it lifted up their hips a little bit. And I never knew about that. And so that's an option for patients that have a dense epidural or who don't have a lot of room in those beds to move.
Right. Yeah. For sure. There's always options. I never want people to sit up here and say, I don't know what else to do. There's always something else you can do. There's always a different movement you can make, for sure. For sure.
And I try to kind of do all my cares together. Like, okay, if I'm going to put a Foley in, or here we straight catheter patients every 3 hours, and then do a Foley after 3 times or something.
Okay.
I try to try to line it up. If I'm going to increase the Pitocin, then I'll move them. I don't, about every hour to hour and a half. But if they're intensely sleeping, the longest I'll go is 2 hours. Yeah. If I'm not already in there before. But for the most part, I try to move my patients, and I was trying to move myself every hour.
Yeah. For sure.
I will. So then I had my internals in. This is Thursday day. I was moving every hour. And then I did every single position. Hands and knees, side lying, peanut ball, no peanut ball, flying cowgirl, which is like now my favorite position to use for my patients.
Same.
It makes people laugh too.
It does.
I did have a patient tell me like, "Oh, I feel like I'm riding a bull," and I'm like, "That's why it's called the flying cowgirl," you know. And I'm like, "Does it?" And I try to tell my patients like, "Does it feel like you're like sticking out your belly?" And they're like, "Yeah." I'm like, "Okay, that's what I want it to feel like."
Yeah.
Yeah. Another trick, which I don't know, maybe I was just trying everything that I could, but I've since used it in like 4 or 5 patients, is I was on hands and knees, which you don't have to be on hands and knees, but I was in a position and I had my husband rub my heel because my grandmother, she had read one time, I think it's the Apache Native American tribe. They used to do this heel rub, and you start from the heel and you just rub outwards, and you can feel that tissue like break up in someone's heel, and that's connected to the cervix.
Oh, apparently. It's like acupressure stuff, basically.
Yeah.
Okay.
Yeah. And so you can feel that. You can feel that heel tissue break up. So in my mind, I'm just visualizing that that's the cervix. And when Jerron was doing that to me, I felt Drew come down.
Oh,
and
wow.
That was the only time on the monitor that Drew had a variable that I saw. Yeah. Wow. And I felt him like literally come down into my pelvis. And then, I think previous to that, the last time I had been checked, I don't remember where it was, but I was like 5 centimeters or something. So I had felt him come down, and then and so I've had this happen with a lot of patients that are like stalled, and I'm like, okay, I don't know if it's just like, if it's true, I don't know if it works. I don't know if it's like a wives' tale or, a Native American, like, like their Native American touch or whatever. But I've rubbed their heel and you can feel it break up, and they dilated and had vaginal deliveries. So
I'm going to need to learn that one. I need to learn that.
Yeah. That's a good one. Yeah. That's it's super easy. Yeah. And you just get like a little bit of lotion or oil or something and really just press onto the heel. But that's my little like tip is I felt it happen for me and my baby. So, and since then I've done it like a handful of times with my patients.
That's really cool.
Yeah. And so then when my midwife, so then that night too, I was still kind of, because I'm like 5 centimeters, my IUPC wasn't tracking adequate contractions, and we had flushed it and everything, and but I could feel them. I could feel like some contractions, and I felt like my belly was getting hard, but the monitor wasn't reflecting that.
Right, yeah.
So that's kind of a little bit where I had a little bit of discouragement, like doubt in my mind, is because I was like, oh, great. If I'm not having adequate contractions, like I'm probably not making any change.
Yeah.
What do I need to think about next? And so I had used this method once in Seattle where they did the what's the beta blocker?
Oh, not the beta blocker. I know exactly what you're talking about too.
Gosh, does it lose my mind every time I talk about it?
And it resets the contractions.
Yeah, like if you're in like a
girl, let me Google it
stall,
because that's about to drive me crazy. Because I can see it in my head. I can't think.
I know. And then when you and I went to Seattle together, they had an actual like protocol about it.
Reset.
Propranolol.
Yes.
Yeah. So I was Googling propranolol, and I could find one trial on it. So I'd asked my nurse that night, I'm like, can you look if it's on up to date or anything? She couldn't find anything.
Yeah.
And because I knew that this hospital had never heard of it. Like, I'd only heard of it. I'd only used it once when I was traveling. And it worked for that patient.
Mm-hmm.
Yeah, it's on the NCBI.
NCBI, okay.
Or propranolol, yeah. And
but it does work.
Studies.
It definitely works.
Mm-hmm.
That
yeah.
and
yes.
Tums they say work too, because Tums are like calcium, and I think it just resets the muscles and all this other stuff.
Yeah, I had asked for Tums. We had done a pit break too. Oh, I forgot to say before all this had happened, before the night of Thursday, like at shift change, I asked for a pit break because I was already at 20 of pit, and to do Tums, and then we restarted it.
Okay.
And so then I, had Jerron rub my heel and all that, and then my contractions still weren't effective. So then I asked, I'm like, can you please look into the propranolol? So my midwife had come, and she was like, well, let me check you. She had read the study. She said, let me check you. And I was like 8 or 9 centimeters.
Oh, well, so, look at that.
Yeah, I know. We didn't need to go down that way. But I was ready. I'm like, there's another option out there. Yeah, and I had also asked too for a certain provider, to be on call for me if I had needed a C-section. So I was kind of like mentally preparing for that too, just because it had been so much time. And yeah, I don't know. But you just have to be open, I think, as a patient. Like, you just have to be open.
Yeah,
but obviously, because I have this background, I knew a little bit more options.
Yeah, for sure. For sure.
So then, I guess this is the part that I didn't really expect to happen is when it was time to start pushing. I was pushing for a long time. And that was what was kind of hard too, is because I'm like, dang, we've made all this progress and I'm pushing for so long. Like, I really don't want to do a C-section. But I do want to tell some listeners, like, positions that I pushed in, just so that they know the options. Yeah. So I did sideline, and I did the tug of war. So I had my feet up, like with the squat bar, and I was pulling on a sheet. So just having that resistance. But the strongest that I felt was my midwife had this birthing stool, which some places have, like, have you seen those blow up ones?
Yes, I have.
Yeah, some places have the blow up ones, but hers was like metal. Like, it's not even. I don't even know. I don't even think you can call it a stool because it's like open and you just sit on it's like a chair. Like, imagine like a chair frame, but like without any cushions on it. Okay. So just the frame of a chair. That's fun. Kind of, but it like it's super skinny, and then I had the stirrups out, and I was using the like bed frame of the bed, and I had an epidural this whole time, so I'm like sitting. So imagine just like sitting on a chair without the bottom, and then I was like using the bed frames with my arms out and like almost like pulling up like a deadlift. Like, if you could imagine like doing a deadlift with a bar or something. But I was kind of using those muscles and pushing down, and that's where I felt the strongest. Yeah. The only thing with that is like the epidural, because it works by gravity, kind of fell a little bit, so I had a little bit more pain because I had like a window that would pop up on my right side where like I wasn't getting coverage. But I pushed my button, and then I had like a heat pack there, and that really helped with that, like, pain. But my midwife started to get concerned because she was just like, why haven't I made that much progress with descent, with pushing so strong? And it turned out my baby had come down like asynclitic, which can happen even when you're moving all the time.
Yep. They just wiggle their little head in one little spot, and you're like, come on, bro, come on.
Yeah. So anyway, he was asynclitic, and sometimes providers can rotate the baby. So I've seen that happen, and I've also seen them kind of rotate babies, and babies kind of get stunned and their heart rates don't recover that well. But anyway, she was able to rotate him, and that's really what changed the game for my pushing.
Beautiful.
So that was kind of a blessing as well. Like, I just felt like I kept hitting these like road bumps, you know, that we just kept overcoming them. So that was great.
And you did it.
And sometimes baby is too low or too engaged to rotate too.
Yeah, true.
Yeah. And so then that changed the game. And then I delivered. And when they said, like, it's really happening, like, there's a difference in what's happening, I was like, at that point, I was like, you're lying. Like, no way is there a difference, because I just couldn't believe it. Like, I'm really going to have him vaginally.
It had been like 4 days. Like, you were probably discouraged as hell.
Super. And I actually don't think I was as discouraged as, like, I don't, because I just kept knowing, like, there's a possibility, like, I'm making change, or I haven't had an infection. But yeah, towards the end, I think I was like, if he does not come this way, like, I think my soul would have been broken for a little bit.
Yeah, because you've done all the things.
Yeah, everyone was so surprised too. Like, you're still in labor, you know? Like, people just, like, didn't believe that I hadn't had my baby yet, or that the doctors would be so patient with me, and midwife would be so patient with me, because I think what you said, at least I've heard from a lot of people, like my aunt, she was like, oh no, if you were having your baby in Utah, like, you wouldn't have had a vaginal delivery, you know? Or similar to what you said, if you were having your baby in the South, you know? But I think it's just a change of culture that needs to happen. Oh, 100%. And the patient advocating for themselves. Like, okay, but are we making progress? And, like, what does progress look like, you know? Because that can be different to each patient. Like, I don't know. I think that's a thing that you just need to discuss with the provider. Like, am I making progress?
Yep.
And the provider will either say, like, yes, you are, but the baby isn't liking the progress or not recovering as well, like, looking at that, or like, no, you're not making progress, but we haven't done everything we can, so let's try to do everything we can.
And that's the main thing. Is there something else we can do? Is there something else we can do? Because 9 times out of 10 there is so but I'm so happy you got your vaginal delivery.
I know. I was so happy too. That did feel like an accomplishment, and I don't want to, like, negate anyone who
no, of course not,
or anything. But, like, I seriously, I think bringing a baby into the world, it just feels like you could do anything. Like, that's, like, you're so strong, you're Superwoman. Like, it felt like, I don't know, it just literally, like, I never felt that happy before.
Yeah.
And I was so unhappy during my pregnancy. That was like,
that was your win.
That just was so crazy.
That was your win.
And so, another bump in the road, which I don't want to scare anyone either, but it's just like, we didn't know what we were having, a boy or girl. So when Jerron announced that it was a boy, he actually immediately had to go.
He what?
Warmer. He actually immediately had to go to the warmer.
Oh, okay.
Yeah, for resuscitation, which that was, you know, scary, but it all worked out good. Yeah, I think that's about it. The only other thing I think that I didn't know as a labor and delivery nurse is when you do use internals, that sometimes they can get a calcium buildup on their head.
Oh, I didn't know that either. I didn't know that.
Yeah, so Drew, he had this like little bump on his head, and I thought it was like it was also along the suture line, so it like worried me. Yeah. But no one was really concerned. They were like, "Oh yeah, did he have an FSE?" And I was like, "Yeah." They said it was a calcium buildup, I guess, from it healing, and then they said that was normal and it would go away.
Okay.
So
yeah, I didn't know that.
It went away. But on TikTok, I did see like someone said that their baby has like a bald spot from that right there. But I don't know.
Oh God.
I would still choose the FSE and being able to move and be as active as I was over like that.
Yeah. I get that. All right, y'all. So we decided we're going to make this a 2-parter. I think because we're so passionate about labor and delivery, and I think Abeth being a labor nurse and me being who I am, we did chat for a while about the whole labor process, which I think was so valuable. But I really wanted to discuss her postpartum journey and how her postpartum journey on the West Coast differs from what we typically see in the South. So we will catch a part 2 with Abeth next time. So stay tuned. Thanks for listening as always. Make sure you follow me on Instagram at _phases of the womb. Or if you need to contact me to send me an email, that's phasesofwomb@gmail.com. See y'all next time. Bye.